surgery is only 50% of the treatment. The rest 50%, which means almost half of the rest of the treatment is physiotherapy. So the process of getting him back on track, I mean back to those days where he used to lift his hand normally, or back to those days where he used to speak fluently, is the job what is supposed to be done ideally in a rehabilitation center. So whereas on one hand Mr. X almost tries to stand in the maybe 3-week or 4-week follow-up period, other hand we see that the Mr. Y comes back in the same wheelchair, the same stage where we discharge him. Physiotherapy is now, it is not 1 month later. This is not an option, but this is what the patient has to go through for the best recovery. So after 6 months you suddenly come out of the blue to my OP and ask me that sir, recovery hasn't happened, we want to get the physiotherapy done now. I'm sorry, there is nothing we can do now. I am absolutely against giving complete bed rest.
Hello everyone, this is Dr. Sai. I serve as Revenue Head for HCAH Suvitas. At HCAH Suvitas, our main focus agenda is to provide the complete comprehensive care for all the patients who need rehab services post-surgery, and for all those neurological conditions, orthopedic conditions, other critical care conditions. So our aim is to provide the best care to the patients around the globe. And today I am delighted to host our special guest, Dr. Teja Vadlamani, who is a renowned and reputed neurologist working at Care Nampally Hospitals in Hyderabad. Dr. Teja Vadlamani is known for his expertise in brain and spine surgeries, minimal invasive surgeries, and management of complex and neurological conditions. With extensive experience in treating conditions like brain tumors, spinal disorders, and traumatic brain injuries, and many neurological challenges which he is doing day-to-day practice, his expertise will help us to know about what is exactly about neurosurgery and what is the role of rehabilitation in neurosurgery. And with all these remarks, I want to invite Dr. Teja Vadlamani to our special podcast. Thank you, sir, for being with us, and we are delighted to have you on board today.
Thank you, Dr. Sai Shravan. Thank you for the kind words, and I'm looking forward to have a healthy discussion about mainly neuro rehabilitation parts, which most podcasts don't touch.
Yes, sir. And mostly rehab means many people understand that alcohol de-addiction center, something like, even people from medical fraternity doesn't have idea about rehabilitation services.
Correct.
So doctor, as a layman, I would like to understand what exactly comes under neurosurgery. Brain, spine or nerves, what is exactly neurosurgery?
So that's a very good question to start with. So as neurosurgeons, we deal with brain, spine, and not only brain and spine, we also deal with the peripheral nerves.
Okay.
So this entire thing comes in the system of central nervous system and peripheral nervous system. So we deal with surgeries related to brain. Let it be surgery for hemorrhagic stroke or infarct. Let it be brain tumors. Let it be arteriovenous malformations. Let it be aneurysms. Okay. So these all come under brain, and even RTA, head injuries, road traffic accidents leading to subdural hematoma, extradural hematoma requiring surgeries. These also come under the brain spectrum of cases. Okay. So based on the condition, it comes either as an emergency or an elective. Whereas the other hand, we have spine. Spine again, it comes either as cervical spine, dorsolumbar, and the sacral spine.
Okay.
So we deal with again emergencies in the spine. It could be fractures or acute onset disc prolapse. Okay. Apart from that, the most common cases that we see in the spine are degenerative disc disease. So you might have heard the patient has disc problem. The disc bulge is pinching on the nerves of the neck, leading to the hand, or it is pinching on the nerves in the lower back, causing pressure symptoms in the legs. Okay. So these cases we usually see in the spine spectrum. Apart from that, there are peripheral nerve disorders also. For example, carpal tunnel syndrome. The nerve here gets entrapped, and then we do some surgeries to release it. Okay. In the same way, there is brachial plexus injuries. So some part of peripheral nerve spectrum also are being dealt with neurosurgeons.
And doctor, in day to day, how people understand about neurosurgery? Will they go to neurologist first, or will they come to neurosurgery first? Will they understand the difference between neurosurgeon and neurologist?
Yeah. So majority of the patients or in general the public don't understand the difference between a neurologist and a neurosurgeon. So putting in easy words, it is as simple as this. A neurologist only treats with medicines or medical management. Whereas neurosurgeon on the other hand is the one who operates on the brain, spine or the peripheral nerves, just like said before. Okay. So if it's a surgical condition, it is definitely a neurosurgeon's expertise which is needed. Whereas if it is a medical condition, most of the patients initially go to a neurologist, right? And they get the evaluation done. Let it be the blood tests, let it be the CT scan or MRI scan or the nerve conduction studies, whichever is needed. Accordingly, they will get the evaluation done. And if this is a surgical condition which has to be treated with a surgery, they refer to the neurosurgeon.
They refer to the
Correct.
So doctor, in your day-to-day practice, how often you interact with neurologist and how often you see the cases in collaboration with neurologists?
Yeah, so neurologists and neurosurgeons are like sister branches. We go hand in hand. Most of the time we take inputs from them. So for example, let it be a stroke. Stroke is very common, So 85% of the strokes are like ischemic strokes. So patient comes with paralysis of one side of the body. Initially, the neurologist sees the patient. If on arrival itself, the patient has a massive stroke, compressing the important areas of the brain, so they directly refer the patient to us for a surgery, right? Whereas some sort of patients, they come in a stable condition. Over a period of time, maybe day 2 after the stroke or day 3 after the stroke increases in volume, or rather I can say the swelling in the brain increases. So in these sort of patients, the referral comes in a delayed manner, maybe on day 2, day 3 for a surgery. So we keep interacting on a regular basis with our neurophysicians, and it is a teamwork. It's not just the neurologist and the neurosurgeon. So we also need the support of the critical care team. So post-surgery or even before the surgery, proper assessment has to be done for the patient every hourly or every half hourly, depending on the criticality of the situation. So it is a teamwork always.
So being an outsider, we always thought of what is the difference between neuro and neurosurgery. So this is a question which goes in our mind.
Correct. In general, most of the people think that everybody is a neurologist, but no, there is a fine line of difference. It's the neurosurgeon who actually does the surgery on these organs.
Doctor, when does a spine or brain condition requires a surgery, or when it can be managed without a surgery?
This is a very good question to start with, because most of the patients who come to a neurosurgeon think that we are going to offer them a surgery, right?
Yes.
So this is wrong. This is not true. So the common cases that we see in our neurosurgical practice are disc-related problems. Let it be cervical spine, let it be lumbar spine. These are the two common areas, right? So if the patient comes only with a pain, right? If it is a neck problem, cervical spondylosis, the pain comes down to the arm and the shoulder, and goes down to the hands. They might have tingling, numbness sensation also, depending on the extent of the disc disease, right? So if these are the symptoms, we can always give an option of medical treatment first, And along with the medicines, physiotherapy also starts even before planning for a surgery. So what does the physiotherapy in the conservative management include? We can offer them IFT, we can offer them TENS, we can offer them SWD. So these are various modalities which help in controlling the pain. So if the patient successfully recovers with the conservative management, that is medicines and physiotherapy, we then start them slowly on the exercises, and maybe they may not need any surgery at all. So 30 to 40% of patients who come with us with a disc problem are getting managed medically, and they are doing well after that. Whereas some patients on arrival to our clinic itself have some weakness. For example, if it is a cervical spine problem, they have some grip weakness, or they might have difficulty in lifting the shoulder above the head level. So these are called deficits. That means they already have come with a presentation with weakness, right? Some patients, the extent of compression on the spinal cord is so severe that they already present with bladder and bowel disturbances. So they may not be able to control their urine, right? They will have urgency. They have to urge to the restroom when they have a sensation of urine, right? Some patients may have effect on the bladder also. So they may have constipation. So if this is the presentation, we advise an early surgery. There is no role of waiting with medicines. So this is related to spine. Whereas in brain, if it is a tumor, suppose. So if the tumor is small in size and the patient doesn't have any symptoms, sometimes what happens is patient might have some non-specific headache. It could be migraine or some other type of headache, right? So incidentally, the CT or MRI might pick up a very small tumor. So there is no role of surgery right away. We tell the patients about the options, and we can follow up the patient. If they develop symptoms or the tumor is showing increase in size with frequent scans that we do, maybe yearly one scan. So if the follow-up imaging shows increase in the size, then we advise surgery. Whereas if the patient comes with a symptomatic tumor, so tumor is maybe 3.5 centimeters or bigger in size, and the patient is already having symptoms. It could be weakness of one side, it could be some behavioral disturbances. Patient might have disturbance in the speech, understanding, cognitive disturbances. So these depend on the location of the tumor, right? So if the patient has these sort of symptoms, we directly advise surgery. So one thing that the public needs to know is that not every patient who steps into our OPD needs a surgery. We manage majority of the patients, maybe not majority, 30 to 40% of patients with medicines. Only 60% usually are given an advice of surgery right away in the first meeting.
So the patients who you advise surgery, maybe generally the patient tendency is like they ask you to do any medical treatment rather than going to surgery.
Yes.
So how difficult it is to make them convince that the surgery is needed for them or it is important for them.
So this is an era of second opinion also. You all know that patients come with us with an opinion already from some other doctor. Yes. Okay. So I can categorize patients into two types. Some patients come for the first time to us, we evaluate them, we get the scan, we advise the scan. And like I said, based on the symptoms, if the symptoms are only sensory, which means pain, tingling, numbness in a disc problem, we try to manage them medically. And if the patient's scan doesn't show a huge disc problem, there is no significant compression, and the patient is not recovering well with the medicines, we have an intermediate bridging option. Okay. So the patient is not a candidate for surgery on one hand, and the patient is not recovering well with the medicines. So we can give some injections, some blocks.
Okay,
or we can
going to surgery.
Correct. Oh, so there is a bridging therapy. Great. So this also falls under pain management category. Okay. So this is an option which is available. Patients who are afraid of surgery, patients who don't want to get surgery because of their old age or some other problems. This is a decent option which controls pain. Okay. And 70% of patients who don't do well with medicines are recovering well with an injection or a block. Okay. Right. So whereas patients who come with a second opinion already, they usually want to listen from us what they want to know. Okay. So patients have an advice of surgery from the other doctor, and they want us to manage medically. So this is one category of patient. Patients who are not happy with the medical management from another doctor, they want us to offer surgery. So basically they want to hear what they have in their mind from our mouth. So it doesn't work that way. We always take decision based on the correlation of patient's symptoms, the patient's examination findings, and patient's radiology. So if the symptoms are matching with the clinical findings and the scan shows a big problem, not a minor problem, there is a huge disc bulge or there is a huge compression of the nerves, and this compression is expected by the patient's problems and the clinical correlation is there. When I examine the patient, there is clinical correlation. Yes, then even though the patient doesn't want surgery, I am obviously going to advise a surgery. So this correlation is the most important thing based on which we take the decisions.
And that too in AA era, maybe patients before coming into the chamber itself, they may search outside your chamber.
Exactly.
And in fact, they will give you some suggestions like, correct, this is what happening, doctor, correct, can we do that?
Oftentimes I see patients coming to me just throwing scans on my face and telling, sir, I have an L4-5 disc problem. So the doctor had advised the surgery. Even AI says that, I need a surgery. What do you think? Or should I go for surgery? How much time do I have for the surgery? When can I plan? So things are becoming handy. Okay. Unfortunately, when we ask AI the same question, the end result will be consult a doctor. We are the doctors.
Okay. Doctor, how was technology, including robotics, increase the precision or safety in neurosurgery?
Okay.
What is there exactly your view on that robotics?
So I think what you want to ask me is in this era of AI.
Yes.
So how is the healthcare improving? So not just coming to the surgery. In this era of AI, just in your household itself, there are a lot of gadgets around you, mainly the mobile phone, right? Yes. So if there is a discussion, suppose your brother or somebody in your house has a disc problem, right? You discuss at your home, that this is the problem that he has, we need to consult a specialist, right? So immediately once you open your phone, there will be a lot of 10 reels on, who is the best spine surgeon, he will make a reel, and what is the latest technology, right?
In fact, doctors are making reels on that.
Exactly. So doctors are making reels on the technology, but the AI is so smart that, it hears your conversations, okay, it is literally into your mind, and whatever you discuss comes on your screen. So AI starts right from even before entering the clinic or seeing the expert at your doorstep. Okay. So this is the first change that we are seeing right now. Okay. And then you can book an appointment at your fingertips. There are so many apps where you can book an appointment. So it is becoming convenient for the patients also. But once you come to the clinic and the doctor has advised surgery. This is what the world wants to know. What is the latest and how is AI being integrated into the surgical expertise, right?
Okay.
So in neurosurgical perspective, let it be brain or spine case, we have a few tools which are actually incorporating AI for a better result for the patient, right?
Okay. Yes.
So let it be latest technology. So for the spine surgery, we are of late using endoscopy. So what happens with endoscopy is it is a more precise and highly magnified view of the nerves that we get through the endoscopy with a very tiny incision. The incision is as small as my fingertip.
Okay.
So previously what we used to do with a 1 inch or a half inch incision is being now done by a less than 1 centimeter incision with the help of an endoscopy.
Great.
We put the endoscope, we view a magnified image of the internal structures where we are, where we want to go in and see, and we can free the nerves. So in the same endoscopy, we are integrating AI in the terms of navigation.
Okay.
So what is this navigation? It is just like our GPS system. Suppose in Hyderabad you want to go from place X to place Y.
Okay.
So you just enter the destinations from your
It will
place
show
to
the-
in a GPS system, right? So it will show you which is a good way to go, which is a blue line, which is a red line, where to
Fastest
avoid.
way also it
Correct?
will
So same thing is navigation. Once the patient is positioned on the table in the operation theatre, we register the patient's position with the existing scan that we do before surgery itself.
Okay.
So we know where exactly are we on the patient's body.
Oh.
So human error can be minimized. So we can use our specific anatomical landmarks that we used regularly, and we can take the help of the AI, which is the navigation system, in placing screws properly. So especially when the anatomy is distorted because of some congenital anomalies, or the curve of the spine is shifted to one side, or there is some TB in the spine where anatomy is disturbed because of that, it gives more precision. And apart from our brain, there is another brain which is added to our and guiding us throughout.
Okay.
Same thing in brain tumors also. So when we are targeting a brain tumor, so after registering the location, we can do the surgery with a smaller cut.
Oh.
So just instead of going all about the place, we know where exactly is the tumor.
Precise to the point.
So we can shorten the extent of the incisions.
Okay.
And even after going inside, we have some specific MRI sequences which can be integrated in the AI. So for example, tractography, functional MRI. So patient suppose has a tumor close to the speech area, right?
Okay.
So we can map where exactly are the speech fibers in relation to the tumor. So
Oh.
MR tractography gives this idea even before planning the surgery.
So this is not possible in earlier days.
This is not possible in?
Is it not possible in earlier days only
Yes,
because of
yes.
this robotics?
So
and
in
because
earlier days, this sort of MRI sequence wasn't there. This sort of MRI sequence is there only since the last 20 or 30 years. Now what we are doing, we are taking the sequence and loading it in the system, the navigation system. So the normal MRI with the navigation and the functional MRI or the tractography is being integrated. So just near the tumor, where exactly are these important fibers has been already registered. Okay, and once you register with the patient head on that particular position during the time of surgery, you know where exactly are you. So while removing the tumor, where can you err, where are you safe, this one you will have an idea. So along with the human touch, you also have integration of the AI. Of course, we have another way of doing this where the anesthesia technology has evolved so that the patient stays awake during the surgery. You might have heard that the patient is playing his violin, playing his guitar, patient is watching a movie during the surgery. So awake surgeries, you keep the patient awake and then you keep talking to the patient. Suppose speech is the area of interest. The patient keeps talking during the tumor removal. So we have a real-time reinforcement to us. As long as the patient is talking, you are safe doing the tumor surgery, right? And once you see any problem, you wait for some time. If the speech recovers, yeah, you can continue with the surgery. If the speech doesn't recover, you are safe leaving that bit of tumor so that you don't give any permanent damage to the patient. The same way, even the navigation or the functional MRI also helps us in assisting the surgery. Apart from that, you have a neuro monitoring. So what does this neuro monitoring do? We place a lot of wires and leads in the muscles of the hands and legs.
Okay.
So suppose you are doing a brain case, you have a control of a facial muscle and then you do multiple wirings in the hands and legs. So as and when you do the surgery, suppose you are operating a tumor on the right side which is close to the motor area. Your area of interest is to look for the power of the left hand and leg.
Okay.
So the brain has a cross connection, right side controls the left hand and leg. So you can in real time have a graphical representation of the same. So as long as the signals are good, you can continue the surgery safely.
Okay.
Once you see a drop in the signal, again you wait for some time. You see other factors like anesthesia related are all optimum. And once the patient is not recovering, then you stop the surgery there. Because removing the tumor fully and giving a patient hemiplegia lifelong isn't acceptable.
Okay.
Right? So you have a real-time monitoring and a documentation that the signals are being good throughout the surgery. If you remove the entire tumor and the signals remain good, that is a good outcome for the patient. Whereas while removing the last bit of the tumor, if the patient is actually having some drop in the signals, it is better to stop there so that patient doesn't develop a permanent weakness. Okay, so these are the sort of technologies that we are using in the current era. And of course, we have other minor applications like robotic arms, which help us in freeing our hands. So they hold our endoscopes, they hold our instruments so that our hands are free. But as of now in neurosurgery, we are using robots along with the surgeons. We don't have an autonomous robot which performs surgery on its own. But I think in the near future we will also see. You might be seeing that so there will be a day in the near future where I can expect that I sit in my OPD or I sit in a remote place and then I guide the endoscope about how to do the surgery on a spine, or I guide a robot to do a surgery on the brain, and then my inputs will be helping the robot to take a combined decision about the patient.
So this is what, doctor, actually you are doing surgery with those robotics, you are making the patient to come out of the danger and giving life to them.
Correct.
So in our rehab, we try to continue the same thing which you done in the hospital.
Exactly.
So after getting that recovery from the hospital, they need to have that complete back to normal life.
The journey
and
needs to
everything.
continue.
Yes.
Yeah.
So like how you are using robotics as one of the part along with the human brain. So we are trying to include this robotics in our day-to-day physio sessions or anything. So there were new technologies like G-Gator, Rymos and everything which we are including in our day-to-day thing to make sure that the life which you are given to the patient will come back to the normal thing.
Yes.
So they can do their normal day-to-day life and everything.
Yes.
So what was your view on this robotics in the rehabilitation kind of?
So definitely, Shravan, because we are using a lot of technology which costs crores of rupees. This is just to make sure that the patient doesn't develop any problems. So whatever we give the result at the end of discharge during the hospital, it has to continue. So there is a process called rewiring. So the brain has something called a plasticity.
Okay.
Suppose this tumor is sitting close to the speech area, or there is another tumor which is sitting close to the hands motor area, especially the hand area. So it is not just as easy as I say that I remove the tumor, the patient is lifting hand. There is a lot of rewiring which has to happen. So the hand may not be as good as it was before.
Okay.
I mean before the tumor started itself. There will be some deficiency or some disturbance. So the process of getting him back on track, I mean back to those days where he used to lift his hand normally, or back to those days where he used to speak fluently, is the job what is supposed to be done ideally in a rehabilitation center. So what most of the patients think is surgery is the end of the story. After that they can take him home and then the journey will continue. This unfortunately doesn't happen in most of the patients. Not few, but most of the patients. Most of the patients need a very guided and targeted treatment even after the surgery. And unfortunately, even the biggest corporate hospitals in India don't have these setups. So it is worthwhile having setups like what you have, to guide the therapy. So it is not just the speech or not just the power. So there are different types of targeted therapies in this. Suppose one patient is able to walk, but he has some disturbances in his gross motor skills. He is not able to grab a bottle as good as he used to do before. So this is called as developing of the gross motor skills. So this is a part of rehabilitation. There is another guy who is able to do gross motor. He is able to grab a bottle, but he is not able to, suppose he is a software professional. He is not able to type at the speed which he used to do earlier. So this is to groom his fine motor skills. Again, rehabilitation center is important, right? Some patients, they will be able to understand what is spoken, but they may not speak out. There is another patient who will be able to speak, but his understanding is poor. So speech and cognitive therapy comes into place. This is also again a part of rehabilitation. Some patients, the behavior is not appropriate. So for example, there is a frontal lobe tumor which is affecting his behavior. So he doesn't know how to behave with one person and what is the difference in behavior with another person. So there is a guided therapy where a psychiatrist is also involved, and again this falls in the rehabilitation phase. So if a patient spends good amount of time in a rehabilitation center as well, only then you can see the final good result. The recovery doesn't end after the surgery. There is still a lot more. This most of the patients don't know.
Yeah, we are saying same to the patient, doctor. We are the continuing of the care which is from the hospital. We are not like an additional optional kind of thing where they want to avail or they want to go back to home, they will go back.
This is not an option, but this is what the patient has to go through for the best recovery. And sometimes patients are ready to go to home, but the attenders will have some anxiety or apprehension, because they will be worried, whether as long as he was in the hospital, somebody was taking care, who is a professional, who has expertise in this field. But immediately shifting to the home, they might have some concerns, like when to give the feeds, what to do next, when to give the medicine. Suppose if I miss the medicine, what next? Okay, so that is where the transitional care of the rehab part also starts. So don't go to the home immediately if you have some concerns. Go to a transitional center where the patient recovers further, and then that will be a gateway to the house next. Right?
Doctor, why do some patients gain faster strength and recovery when compared to others when they had similar surgeries? So what exactly may be the reason behind this?
Suppose there is one Mr. X with the same spinal cord injury at the cervical level who comes with a quadriplegia, and on the other hand there is one Mr. Y who has the same sort of spinal cord injury, comes in the same quadriplegic state. Okay. Both initially get the surgery done as per our advice, because there was compression on the spinal cord. Okay. And consider that both of them are in the similar age group with almost same comorbidity profile. Okay. So what we regularly see is they usually after the acute phase, so once they are out of the ventilator, the acute phase, that is the surgical part, is all done, we usually advise them to go for the rehabilitation phase. So based on the center where they get the rehabilitation done, and based on the extent and the technology also definitely which is being used in the rehab center, we can see a drastic difference in both Mr. X and Mr. Y. So whereas on one hand Mr. X almost tries to stand in the maybe 3-week or 4-week follow-up period, other hand we see that the Mr. Y comes back in the same wheelchair, the same stage where we discharge him, right? Okay. So what the patient attenders have to understand here is that surgery is not the end of the story. Surgery is just a method to free the spinal cord, but after that the rewiring has to be guided. Whatever we say, the rewiring of the spinal cord, which has to happen, it happens spontaneously, but if it is guided by an expert, there is definitely a great change. Okay. Like you can see Mr. X is coming in a standing state. He almost tries to walk in my OP in the follow-up visit after a month, but Mr. Y is not able to do that. Okay. So similar injuries, there is a difference in the approach of the patient attenders. So what happens is patient attenders most of the time feel that once we get rid of the surgery part, there is nothing much to do. He will recover on his own, but this is totally false. Yes. Okay. So you have to have the right people at the right time, and believe me, physiotherapy starts day one after the surgery. Okay. The physiotherapy part. So once the surgery is done, we don't give too much rest for the patient. We start bedside physiotherapy first. If the patient is already making a very good recovery, yes, we put them to wheelchair, and then we can slowly shift them to the rehab center. Okay. Once they don't have any other problems with the vitals or other issues like infections, right? But if the attenders are not focusing on the rehab part, usually in India the problem will be finances. So initially they spend a lot on the surgery, there will be surgery related implants, there will be a big bill initially, But after that, either they are drained out of finances or the attenders lose interest. Most of the time they take it for granted that this patient is not going to make it again. Okay. He will be bedridden for life.
They take it as granted.
Yeah, they take it as granted. So considering this in their mind, they don't bother about going for a physiotherapy part. Okay. So this is the key difference in patient X and patient Y. Patient X attenders, of course, putting finances apart, they were very keen on getting the physiotherapy done. Yes. And once it was done in the proper center, he came almost in a walking stage. And I believe that he will improve further in the same center, right? Whereas Mr. Y, they kept him at home. Maybe 1 or 2 days the physiotherapist had come, and after that even he was also not being allowed to come because of other issues. Okay. So he was just neglected after the surgery. So obviously you don't see much recovery. So I think this is the key difference. Indians as such, they think that surgery is the miracle.
Once surgery is done, everything
correct.
He will recover
so
on
what
its own.
As a neurosurgeon I want to tell the public is that surgery is only 50% of the treatment. Yes. The rest 50%, which means almost half of the rest of the treatment, is physiotherapy. If you do the right physiotherapy at the right time and early physiotherapy, and if you have a dedicated center where the advanced technology is also being used, it makes a tremendous difference in the recovery.
So early rehabs always plays a vital role in getting back to his normal life.
Exactly, yeah. We have seen a lot of patients who do well if they are in a proper center where the rehab facilities are very good, right? And not just this. Just imagine the patient, let it be Mr. X or let it be Mr. Y. So you are walking yesterday, you had an accident and then your spinal cord is injured. Just imagine yourself lying on the bed, you are not able to move your hands and legs. It also has a psychological impact on the patient, right? So not just rehabilitation or physiotherapy or a physical exercise, psychological support is also very important for these patients. Okay, so the right environment again comes to place. I agree that home is a good environment, but just keeping in a place like home without focusing much on physiotherapy doesn't lead anywhere. Whereas keeping in a good physiotherapy center where the technology or the expertise is being used and the patient himself is seeing some results, like yesterday maybe he was not able to move his fingers, now he started to move his fingers. Before that he was not able to move his toes, now he is able to fold his legs. So these improvements also have a positive reinforcement on the recovery of the patient.
And particularly when the person is that earning one in the family.
Correct.
So
if he is the only breadwinner.
To get back to normal life.
Exactly.
In this early rehab will play a vital role,
Correct.
I think, in
Correct.
getting back to normal life.
Correct.
So doctor, how do you feel when patients are ignoring your advice of going to rehab and after seeing them not getting recovered for months together? So how do you feel and what do you want to suggest them at
That's
that
what
point?
we always suggest the patient once we discharge from the primary center where the surgery is being done to go for a good rehab center where the physiotherapy will be started right from day one itself, on the time of admission itself. But like I said, unfortunately because of some other constraints, let it be some problems within the family or financial constraints, most of the patients are not able to do that. Okay, so 2-3 things that I want to tell my patients, especially in the path of recovery, is that physiotherapy is now, it is not 1 month later. Yes. Remember, I had done this surgery, you want to get the physiotherapy done 1 month later because your mind has changed or you get some money. It doesn't work that way, unfortunately. Rewiring is an ongoing process and you have to support it today, not tomorrow, not a 1 month later or not a 1 week later. These things will be, detrimental to the overall patient outcome. It has to start now and it has to be ongoing. Yes. Maybe let us take a time frame of at least 1 month, 2 months and 3 months from now. What I usually tell my patients is it takes about 3 to 6 months for the recovery to happen. So after 6 months you suddenly come out of the blue to my OP and ask me that, sir, recovery hasn't happened. We want to get the physiotherapy done now. No. I'm sorry, there is nothing we can do now. Okay. So it has to start now. Now is the time when I discharge them from the hospital. And it has to be ongoing. Of course, yeah, if you see good results, you can take him home maybe after a 1 month. Yes. You will see the changes in the patient, right? So the exact duration in the rehab might vary from patient to patient, but it has to start now. Now meaning immediately after the surgery.
The intervention is important at the early stage.
At the earliest, correct.
Doctor, how important it is to start early rehabilitation to avoid that stiffness, weakness or long-term disability of any patients who are doing surgery?
So, most common problems that we see in patients who don't go for early physiotherapy or who totally neglect physiotherapy are the complications of paralysis. Oh. So, if it is a brain stroke, there is paralysis on one side. Okay. If it is a spinal cord injury, based on the level of injury, the patients will either lose power in both the upper limbs or all 4 limbs. Okay. Or both the lower limbs depending on the level of the injury. Okay. Right. So if the patient is not going for early physiotherapy, they can develop some complications like spasticity. If the spasticity is being severe and being neglected for a long duration, they develop some infolding of the hands like contractures. You might have seen some patients walking in this attitude. Their leg also will be turned inwards and there will be change in the walking style. So if the physiotherapy is not being addressed, like I said, even immediately after the day of surgery also we focus on physiotherapy right away on the bed itself. Even though the patient is not able to wake up, even though the patient is in coma state, we start the physiotherapy bedside itself. Okay. So this helps in preventing long-term complications like spasticity, contractures, so that in future if the brain rewires and then sends signals which give a potential for a good recovery of the limbs. If the patient already develops a contracture, he will be not able to use the full power of that limb. So preventing the complications of long-term bedridden status or slow recovery.
Preventing the disability.
Yeah. So disability avoidance is also an important part of the recovery, which is being taken care mainly by early physiotherapy and continuation of the same.
Okay. Doctor, you are saying about neuroplasticity and all. So in simple terms, how long brain will take turn to relearn all these things to rehabilitation? So what is exactly, is there any time period that brain will relearn all these things to rehab, or what exactly it is about neuroplasticity?
So the problem with our system, that is neurons, is that once damaged they don't regenerate.
Okay.
right? However, brain has some concept called as neuroplasticity. So what happens here is, you know that brain is a cluster of millions and trillions of neurons,
Yes.
and so many are the circuits also. So just imagine going inside a transformer, checking all the circuits. So brain is just like a transformer for the body, right? So every signal for anything you do comes from the brain. Okay. So once, because of some stroke or because of some tumor, the circuit has been disturbed or damaged. Once the neuron is damaged, the neuron doesn't grow back again. However, by the plasticity, brain tries to make some changes so that the functional part of the brain takes over a little bit of function from the damaged brain. Okay. And the brain tries to develop some extra networks or circuits which can try to take over the function by part. However, the neurons don't grow back again. So plasticity usually takes a slow time. Suppose in a simple disc problem, suppose the only problem is that the nerve has been compressed. There is no internal damage of the nerve. So the patient usually has some pain, tingling, numbness, which usually recover early. Whereas if the patient already has a foot drop because of a disc problem, this takes about 3 to 6 months time, provided you have a good guidance. The guidance being the physiotherapy. Okay. Suppose it is a stroke and it is a massive stroke. So which means that the area of the stroke, whatever the existing neurons, are totally damaged. So in a massive stroke, you can only achieve limited functional ability of the patient because the neurons are actually damaged. You can't get back the 100% function. However, some patients, because of the plasticity, some part of the function is coming back. Suppose the patient had a left side stroke. Some patients develop hand grip weakness, but leg is good. They will be able to walk with a 1 or 2% support. In some patients, we see that the leg is weak, but they are able to lift their hand, grab some objects. So there is variation in the pattern depending on the neuroplasticity. So what I want to say is the transformer is injured, and in the recovery phase, your body is running on a generator phase. So what happens when you are on a generator at home? You tell everybody at home to switch off unnecessary or power consuming appliances. So you tend to switch off the ACs, you tend to switch off the other power consuming this thing like microwave oven.
Necessary things.
Yeah, correct. So fans, lights become necessary. So in the rewiring process, the person has to know which is the target muscle which has to be addressed properly. Okay. So if the person who has an expertise is taking care of the patient, they will be able to assess the strength of the muscles in each group. How much is the strength in the proximal upper limb? How much is the strength in the distal upper limb? So this is like prioritizing our appliances when you are on a generator mode. Once the recovery is coming, you see some changes, you switch on to the main mode and the patient is back on track. You can switch on all the appliances. So it is the same way as the patient gaining full functional recovery. So the difference of which appliances have to be prioritized is the analogy here. Which muscle has to be prioritized? You target some other muscle which is not being affected, and you don't target the muscle which is actually being affected. Doesn't make sense. So this is a structured plan that we have. So in the process of rewiring, if the plan is structured and under the care of an expert, it will lead to very good results.
This will come the rehab role, the multidisciplinary team or the therapists who are involved. They can able to guide them.
Correct. A person who has an expertise in a neuro rehab will make a better outcome out of his patient compared to a person who may not be very well trained in a neuro rehab.
Then it will help us brain to relearn again the things on a faster mode. Doctor, usually this neuro recovery is been handled by only one specialist. So how important it is to have a coordinated team like a physiatrist, occupational therapist, speech therapist. So how important is to people involved in this recovery part?
Yeah. So like I already said, even in the main hospital, it is a teamwork. A neurologist, a neurosurgeon, and we also have some basic physiotherapy in our setup and the critical care team. So if everybody is working together, only then we can get the patient out of the main hospital. And same thing again continues in the rehab center as well. So like I said, the patient who has a spine injury, he's aware that he's not able to move his legs or hands properly. So he's already psychologically disturbed. Yesterday he was walking, suddenly he's in a bedridden status today. A stroke patient who is able to recognize that he's not able to move one side of his body, again goes through the same mental trauma, right? So even a psychiatric counseling and a regular psychiatric follow-up also falls under the spectrum of rehabilitation, right? And what most of the people know is doing regular exercises, strengthening the muscles that are weak, rewiring this process, that is also there. So in this again there are two aspects, fine motor skills and gross motor skills. So making the patient grab something, making the patient stand, making the patient walk, making the patient sit, these are all gross motor skills. Whereas a patient who is able to do all these things but not able to fine motor, suppose a patient had a disc at C7, T1 or a C6, C7 disc which is causing a grip weakness. So his only focus is to strengthen his grip, and poor fellow, he has to go back and work in the system for hours together. So his main focus is not to walk, not to sit, not to stand, not to lift his hand, but to work on the system, for which his fine motor skills has to be carved, right? So this is where vocational therapy comes into picture, okay? And apart from this, some patients may have a problem in the lungs. Suppose it is a cervical spine injury and the patient has diaphragmatic palsy. So getting back the power of the diaphragm so that he will be able to do his inspiration better again comes under the respiratory therapy part, right? And some patients will have some speech disturbances, especially the patient has some problem in the speech area. So again, speech and swallow therapy comes into picture. So this is a team of people in the rehabilitation who take care of fine motor skills, gross motor skills, psychological disturbances, as well as vocational and occupational therapy. So it is a cluster of all these which is included in the rehabilitation phase.
So this also throws a light that we need to choose a rehab where this
all the facilities
available, all the facilities has
Correct.
to be there.
Correct.
And they need to work as a team.
Exactly.
To
Exactly.
have that milestone based recoveries for each and every patient.
Correct.
Because as you told doctor, every patient has their own problems.
Exactly.
So one may require speech therapy, one may have that occupational therapy and all those things.
Correct.
So that milestone based everything we need multidisciplinary team, particularly.
So the treatment is always tailored to the patient. It is not that one sort of rehab program fits everybody who comes to the rehab center. It is tailored to the individual based on his requirements, what he has to do tomorrow or after a month.
For this we need an expertise team to available there in that rehab.
Exactly.
Doctor, many families think that rest is the biggest recovery strategy. So how often it will impact that recovery of that particular patient if they are thinking that rest is a biggest option for them?
So this is a misconception among patients or their attenders. Let it be even post-surgery recovery, or let it be a simple disc problem with which the patient comes to our OP. I am absolutely against giving complete bed rest. I mean, rest can be limited to the area of the where the problem is there. Suppose it is a problem in the neck, there is a cervical disc disease. I would advise the patient to take some precautions or rest only for the neck part. And if it is a lumbar disc problem, I would advise precautions or rest only for the lumbar area. But the patient otherwise could do most of the activities which he is doing, except for some restrictions. Okay. The problem with giving prolonged rest is you are already in pain. Your body says to take rest. Okay. But if this pain is going to a chronic pain, which means any pain more than 3 months of duration, right? So just imagine the fate of your muscles because of the prolonged continuous rest. So your muscles won't be as strong as they were before 3 months, right? And even if after 3 months you decide to go for a surgery because pain is still bothering you, even if you're resting fully, the pain is not getting relieved, right? Post-operatively also, these weak muscles take some time to regain the strength. Already the nerve is getting pinched and your muscles are not getting good signals from the nerves, right? So in the post-operative phase, these weakened muscles will take more time than another normal healthy person whose muscles have been kept in tone, right? So absolute rest is not indicated for every condition, especially in a disc problem, and even rest in terms of patients who undergo surgery. As soon as possible, we try to get them out of the bed and make them walk for patients who undergo surgery for simple spine issues. Whereas for patients who have a stroke or who have a cervical or dorsal spinal cord injury, these patients also we try to start the physiotherapy as early as possible. If the patient is able to sit and walk, we do that as early as possible. However, the patient is in a comatose state or not able to move the limbs, it will start the very next day at bedside itself. So giving rest to the muscles becomes negative for our recovery overall.
Because most of the Indian families think that taking rest itself will heal the body.
So yeah, I mean what I should say is relative rest to that area, but complete rest. So if you have a disc problem, like lying down on the bed for 2 weeks doesn't make any sense to me at least.
Okay. So doctor, how families' questions are like after surgery, how family will they ask you that sir complete rest is required, or can we go for work, or we can go for rehab? So how long it will take for rehab after our surgery? So is that common questions you see in your day-to-day practice?
Yes. So it all depends on the nature of work that the person is going to. Suppose the patient undergoes a lumbar disc surgery and he's a heavy worker. Imagine he's an agricultural worker or somebody who carries heavy weights in his routine day-to-day activities. So these sort of patients, we try to guide them in going back to their routine life, and we try to advise them, maximum to avoid any heavy acute bending on the back. So they can go back to their work maybe 2 to 4 weeks based on the recovery pattern. Now we are doing minimal invasive spine surgery. So with minimal invasive spine surgeries, we have seen our software professionals going back to work from home in day 2, day 3 after the surgery.
Immediately.
So let them take a call based on how good the pain relief is. You can go back to work early, but what is the nature of the work is the point here. So if it is a simple work where you can sit and work for some time, yes, maybe the day after the surgery also you can start little work, slowly increase the duration of your work. But whereas if it is a heavy work, like it is an agricultural worker who has to lift heavy objects, I would specifically ask them to avoid as much as possible bending on the back and lifting heavy weights. They can do other types of works where they stand for some time or sit for some time and maybe supervise sort of work.
End of the day, they need to work, not like complete rest.
Complete rest is nowhere, what we need, and even the patient doesn't like it. Even as surgeons, we also don't like giving them a complete rest.
So irrespective of
they have to be active with some precautions.
Irrespective of their professions, like either it is software or it is the farmer or everyone, they has to work accordingly.
People are also asking like, how early can we go back to gym? And we enjoy playing a lot because a lot of stress at our work. So when can we go back to playing cricket or playing tennis? So yes, most of the patients are going back to their work, but depending on the recovery, we would always like to follow them up, and maybe 1 month or 3 months later, based on the recovery, we will advise even to go for sports and games as well, or going for a gym also, but with some precautions. Definitely take care of your back while doing these activities, or take care of your neck while doing these activities. With these precautions, they can go back to work. And with minimally invasive surgeries, like I said, day 2, day 3 also we are sending them back to work. But absolute rest or prolonged rest is not a concept in neurosurgery, at least today.
Because even after making them understand, patients after going back to home, they will start taking rest.
Yes.
Even if they are working at home, even if they have some software people, they think that working itself is a kind of thing.
Stress.
But in fact, it is rest which they are taking to their body part. Fine. Doctor, does this robotic or minimal invasive surgery reduces the rehab requirement for that particular patient, or still rehab plays a vital role in this kind of surgeries? So what's your opinion?
So this is a very good question actually. So based on the condition in which the patient comes, suppose there is one patient who just has pain but no weakness. His pain is not going away with the painkillers. So we advise surgery for this patient because he has continuous pain even in spite of using the painkillers, right? There is another patient who comes with pain, along with that he has some foot drop because of the lumbar disc problem, right? So these are two different scenarios. The first patient only has pain, the second patient has some disability also. He is not able to walk properly, his footwear is slipping off, right? So whatever minimally invasive surgery you do, this only reduces the extent of muscle damage during the surgery or bone damage during the surgery, okay? So in a routine surgery which we used to do, open surgery 30 years ago, we used to make a big incision, cause a lot of muscle damage unfortunately, and remove a big chunk of bone, right? Whereas with minimal invasive, maybe endoscopic spine surgery these days, the incision is quite small as the tip of my finger. We go in some areas we may not be removing bone also. However, in some areas we remove only a small chunk of bone, which is 10 to 20% of what it was used to be earlier, right? And we see the nerves very closely, and the extent of injury to the nerves or damage to the nerves is also very minimal, okay? So what happens with these surgeries is that the collateral damage, the damage to the normal muscles, normal bone and the normal ligaments, which we should ideally not touch during any surgery, is minimized. However, if it is the first type of patient who is pain free, he can go back to his home. He may not need a big rehab program, and he will be recovering automatically because pain was his only complaint. Once he is relieved of his pain, he can make a good recovery. He just needs some basic exercises, okay? Whereas the second patient who comes with a foot drop, whatever minimally invasive surgery you do, for his power to improve, you definitely need to have a good guided rehabilitation program, okay? Because the concern here is not just relief of the pain, the concern here is also to get him improvement in the muscles that have lost their power. So for this he will need a dedicated rehab program. So it all depends on what condition the patient has come to us. If he already has a weakness, rehabilitation has a significant role, and it may be needed for a longer duration also, especially when the power is very weak on arrival. Whereas if it is a patient who just comes with pain, he may not need a long rehab program.
Doctor, beyond this surgery, even these rehabilitation centers are evolving with latest technologies like advanced robotics, digital tracking system, and advanced therapy equipments. So how do you feel all these are playing a vital role in neuro recovery?
Yeah, definitely. So since we have seen a lot of changes in the way we perform surgery, like we have discussed, we are doing surgeries in a safer manner. We know where we are safe, we know where we are not safe, and while doing surgery we are constantly monitoring the extent of injury that we are causing to the nerves, whether we are safe by removing this extra bit of tumor, whether we are safe by putting the screw in this trajectory. So we have a constant monitoring. So having said that, once you use this much of technology just to perform the surgery, in the post-op period, if you don't have any advancements, that is a misconception, right?
To match that level.
Yeah, so we have so many advancements, mainly with the use of AI and robotics in the rehabilitation phase also, right? So we have something called an exoskeleton, which maps all the muscles of the patient, mainly targeting the muscles which are supposed to get the recovery in this phase. So this keeps a constant track of the activity of the patient, and it gives a day-to-day analysis of how well he is doing compared to last week and how well he is doing in over a period of month. So I think if we remove the term patients and use some cricketer or some footballer, people will understand this very easily. So same technology is being used to track the recovery of the muscles and joints of the patients also. In similar way, we are using augmented reality, virtual reality, where patient not just does the physiotherapy, but it is a sort of engaging and fun activity also for the patient. You use some VR glasses or give them some tasks which are similar to some video game sort of thing, where the patient enjoys the 1 hour or 2 hours he spends in the rehab room. And apart from this, there are advanced robotics where the patient is made to stand, they give the gait training, okay. So literally the patient will be amazed to see that, immediately after shifting to the rehab center, he will be having a lot of robots which assists him. And these robots are smart and they have AI integration, so that the extent of the involvement in various patients is different. It is not that one patient has this much of activity and the other patient has a different one. It tailors the extent of support for each patient based on what muscle tone which he has on arrival, and based on his day-to-day progress, the support system changes. So it's a constant and dynamic thing which is happening. So same way how we are using the technology, I think this helps in better and early recovery of the patient, and to reach the final end point. This will guide him in reaching the final end point, and you can also store the statistics, because talking doesn't mean anything. You need to show the statistics. A patient has to come to me, he just opens Google and see the reviews, okay, so 4.6, 4.9 rating. So that number is what strikes him, right? The same way you can also measure the improvement in various muscle groups, and this can be shown to the patient and their attenders also, so that they trust that the journey is on the right platform and the right track.
Rather than talking, we can show with specific numbers and everything of the recovery part. So, doctor, will you think that these robotics are reducing the time of recovery for the patients?
Yes, definitely, because there is a one robo which helps in gait training, or there is this exoskeleton which keeps a track of the patient's joints and muscles. Okay. The work that 4 to 5 physiotherapists would do is being handled alone by this one machine. So there is only one person who needs to run the machine, and the other 4 to 5 people can do some other work, and they can address the issues of some other patient. So the manpower is being reduced, and in the same way we know which muscle has to be addressed specifically.
Also that pinpoint to
correct, it pinpoints to the exact extent of the damage which different groups of muscles have. So which muscle needs to focus better, which muscles it needs to focus less. So there is an analytics of all this, so that it delivers what exactly has to be done. This data is being taken, it is taking the feedback of the patient and improving itself day by day. So these sort of technologies definitely help in earlier recovery, and again these are patient specific. Each patient will have his own algorithm.
Doctor, what are the measurable milestones a patient should look after neurosurgery? in the
So
recovery
again,
part?
yeah, so definitely a very good question. We learn in pediatrics that there are some developmental milestones in newborns,
Yes.
right? So there is a specific time when they smile, there is a specific time when they hold the neck, there is a specific time to develop stranger anxiety. So yes, definitely there should be some milestones which we have to keep a track of,
Okay.
and these vary from patient to patient. Suppose it is a simple patient who undergoes a disc surgery and his only complaint is pain. Okay, so his milestones will be like compared to the pre-surgical status, what is the amount of duration he is able to sit now?
Okay.
What is the amount of duration he is able to stand now? How much is he able to walk better than previous condition, right? And how well is he able to sleep? How well is he able to do his day-to-day activities? And how well he is able to do his regular work? So these are the milestones that you usually look for in a patient who undergoes a simple disc surgery. Whereas if it is a patient who has a stroke or a spinal cord injury, these milestones are different. Just like a kid, you have to nurture him and then keep a track of milestones that he has to achieve. Suppose it is a patient who has a right-sided stroke in the brain. He will have a weakness of the left hand and leg. So compared to the previous stage, how well is he able to lift his arm? How well is he able to bend at the elbow? How well is he able to grip? How well is he able to stand? How is his sitting? Is it a normal sitting? Is he able to do the high sitting? Okay. How many steps is he able to make compared to the previous condition, that is at the time of arrival to the center? Okay, so these are the milestones that you track in these patients. And if it is a patient who has a spinal cord injury in the cervical spine, even bladder and bowel control also becomes a milestone.
Okay.
So apart from the recovery of the limbs and the muscles, you also see for recovery of the bladder and bowel sphincter muscles. So is he able to get the sensation of the bladder filling? Is he able to say that he is able to pass the motion? Once the motion is passed, is he able to know that he is passed? So these might sound silly, but they become an important aspect of patient's recovery, because person just lying down having no control on bladder and bowel also is a very problematic thing for the patients.
Because most of the people will think just sitting and standing itself are the milestones.
Correct.
There are so many
So many
milestones
others.
which are
If you
involved in the
see,
recovery part.
because you are leading a normal life, these may not sound big to you today, but once it is a patient who has a neurological injury, everything becomes important. And in the same way, if the patient has some problem in the left temporal area, his speech will be getting affected, right? So how well is he able to understand or comprehend to what commands we give? How well is he able to speak out? Is it a single syllable? Is it bisyllable? Same like what we do for kids. Is he able to make some sentences? So compared to the day of arrival, suppose he is just blabbering some words. How well is he able to form the sentences? So these become the milestones for the speech. So it is just parallel to how you see in the newborns. So gross motor milestones, fine motor milestones, social milestones, language milestones. Based on the patient's conditions, we also see similar milestones. We usually tell our patients who lose power on one side or who lose the ability to speak after a stroke, saying that treat them as a young kid.
Okay.
Just like you have a son at a home. So now the problem is with the father. So just imagine that he's not your father, he's your son today.
Okay.
So what all books you are giving to him, what all the videos you are showing to him, like phonics or maybe A for apple, as simple as that. Start from basic level. So slowly with speech and swallow therapy, he will get better. The same way for the gross motor and fine motor skills also. So these milestones are very important to keep a track of, and when we see the patient back in our OP after a month or so, we grossly check these. And we will tell the patient, when he left from the hospital, he wasn't able to stand. Now he is doing that on his own. When he left from the hospital, he was not walking. Now he is making 3 steps at a time.
Okay.
And when he left from the hospital, he was not understanding my commands. Today he is able to do that. And is able to say his name, which we wasn't able to do back then. So these are the milestones that we look in the patient.
Also, we discussed a little like this multidisciplinary team will help us a lot in deciding these milestones and making
So
them.
is it a gross motor, is it a fine motor, is it a speech which has to be addressed in particular, and about the psychological part of it. If the patient is very anxious, apprehensive, going into depression, this also has to be addressed, because if the patient is severely depressed post his stay in the ICU in the primary hospital, after that he comes to the rehab, and this part is also not addressed. Just imagine a depressed patient versus a happy patient at the end of recovery. A happy patient will give the best functional recovery. A depressed patient may not give the best output. He might be able to move his hands and legs, but the final recovery will vary between the patient who is happy whereas a patient who is not very happy or in a depressed state. So every aspect, there are different milestones, and everything has to be addressed in particular, keeping that particular patient in the mind.
And also choosing a particular or any specific rehab for achieving this milestone also very crucial.
Yes, multidisciplinary team.
Yes.
Having a multidisciplinary team is very important.
They need to check that whether speech therapist available
Exactly.
or occupational therapist.
So, which all has to be given and
Physiatrist.
which needs more focus. Both these aspects have to be covered.
So doctor, when you see patients coming back to you after 1 month or 2 months of your surgery, so how do you feel if they are going to any rehab, coming with good recovery, and would you feel bad if they are coming without any progress after the surgery, ignoring your advice of going to rehab? So how exactly you feel at that point of time when you see them?
So, to start with, as a neurosurgeon, or I know not just me, most of the neurosurgeons, maybe 100% of the neurosurgeons, our moods change at home based on the recovery of the patient, right?
Oh.
So, if I operate a patient whom I expect that he is not going to make it, if he survives, that is a big miracle. So, we feel like literally, we just do a supportive surgery, okay? If the patient survives, that is an initial boost for us. So, we sort of express that happiness in various activities even back at our home. Some patients we know they are not going to make it, okay? So, we feel depressed and dejected in our own homes. My mom would ask me like, you're not eating well for the last 2 days, what is wrong? Then I say, I had performed surgery on the patient, he's not doing good. So, just translate this to a 1 month later picture, okay? A patient whom I had operated on, okay? Initially I feel, okay, he's stable, let me discharge to a rehab center. Or this patient had a stroke, good that he survived, now let us see how he is going to improve. So, coming back in a walking state, in a talking state, or or a patient who goes on a wheelchair in a spinal cord injury, coming back to me walking, maybe we should do a party at home.
Yes.
So, this is the sort of mental picture that I have. Okay, we do a mini party at home because though we know that we are just doing a supportive surgery, by God's grace and by being in right hands at the right time, proper guided therapy, it always gives us immense pleasure to see patients coming back walking or with a very excellent recovery to our OPs, and they literally make the day for us.
Yes. That is the other part of the story where you feel satisfied that the patient
Exactly,
is happy. Now
exactly.
he's back to his normal
Yeah.
life.
Initially, when we discharge, our targets are like patient is stable. He has survived through this injury. Okay, now let us see what happens. But seeing a patient whom we expect that he is not going to make it, he is going to succumb to this injury, coming back walking to your OP, just imagine the pleasure you are going to get through that.
Does this happen anytime, doctor? You advise them to go to rehab. They won't come back to you. After 1 month, ignoring your advice, going to home, and like how you discussed earlier, taking rest is the biggest thing which they look forward. And after coming back to you after 1 month and seeing the patient condition is the same process. So how do you feel at that point of time?
Of course, this is the opposite feeling of what we discussed previously. We feel depressed a bit. We have to see a lot of patients. Unfortunately for our doctors, this patient will create a picture where we feel depressed. The patient, we expect that at least some power should come back, if not 100%. I don't expect that all patients after spinal cord injury will walk normally, but at least if they can become independent for doing their own activities, that is also a satisfaction. But unfortunately, some patients don't make it, and like I said, it is the opposite situation of the previous situation. We feel little depressed. Unfortunately, our doctor profession is like we can't carry forward to the next patient.
Yes.
Immediately we change our mood, and then we have to please the other patient also. But yes, definitely it will have a negative impact, at least for few minutes or few hours on our that day, that part of the day-to-day life.
What I feel is every time you will reset yourself before each and every OPD.
Correct.
When any
Correct.
patient comes.
Because I perform a surgery up there in OT, and then I know that the patient is not going to make it, or some patients may not make it. We declare them and come back. There is another patient waiting in our OP with a hope, expecting that this doctor is going to give some good news to us, or maybe he is going to offer some good treatment to us. So I can't carry the negative emotions of the patient up there in front of the patient here. But having said that, like you said, a patient who comes with a very good recovery, maybe I will translate that joy to the next patient also. I will counsel the patient, spend some more extra time, because these human emotions are funny.
Yes.
One patient gives me a happy feeling, I transmit it to the other patient also. And in the same way, one patient whom I am not very happy with the recovery, at least 10-20% of this will affect the next patient also.
Doctor, maybe in day-to-day your practice, you may be seeing mixed emotions. So many patients, like you are saying, some patients will give you happiness with their recovery. Some may give you that sadness, ignoring your advice at that point of time. So how do you manage yourself, or how do you keep yourself energized throughout the day instead of having all these mixed emotions in your day-to-day life.
So like you said, sometimes we are in a situation where we have to declare that one patient is dead in our ICU. At the same time, we know that there is another patient waiting with a hope in our OPD who expects us to see, give them some guidance, give them some advice. We have the ability to translate the emotions of the patients just by talking to them well. Okay, so for good or bad, we doctors sometimes become emotionally blunt. We don't carry forward the emotions for a longer duration. Okay, so once the bad patient, sick patient episode is over, we translate and we have to change our face. We have to counsel the other patient. So a new patient is a new hope to us. We expect that we treat this patient in a better way. Okay, and having said that, our principal motto in any medical practice is primum non nocere, which means that do no harm. So patients come with some problems. We try to support them, maybe offer surgery or without surgery. We try to support them and then get them on the safer side, or try to revive them, make them survive through our skills, what we acquire through our practice, right? Unfortunately, you are not God and you can't make everybody survive. When the injuries are severe, when the stroke is massive, sometimes in spite of the best team effort, the patient doesn't make it. So we accept this in a day-to-day life. Sticking to one patient doesn't make sense to another patient who is waiting with the hope. So we try to rebalance our emotions and we try to keep motivating ourselves, saying that, we are just transducing what God has given our skills, but we actually don't have a capacity to heal everybody or, save everybody's life. So these things we keep running in our mind. Definitely, yes, there will be some impact of that patient who expires on our mind, but unfortunately we can't keep doing that for the rest of the day. We have to shift our moods, give hope to some other patient and treat other patient who is waiting with fresh hope and fresh feelings in our OPD.
So what is that one thing which motivates you, doctor?
So the one thing which motivates is my other patients. Okay. So there are so many patients whom we treat well. Maybe of hundreds of patients, only one may not recover well. So we think of those 99 patients whom we treat well, or who are already gone home in a good shape. So previous patients motivate us to do better, and definitely yes, some sort of recreation like exercise, spending some time with family, spending some time with our kids, music. So these things also come to our aid when we are not in a very good mood.
Doctor, if you have to tell one thing to the families, so maybe surgery fixes the problem. So what is that one thing which will help them to get that quality of recovery back?
So I think this is the take-home message from this podcast. So I don't truly agree to the fact that you said that surgery fixes the problem. Surgery fixes 50% of the problem.
Okay.
It is not 100%, especially for a patient who comes with a stroke or a spinal cord injury. Surgery just relieves the compression of the nerves or facilitates the patient to survive. But are you happy if the patient just survives but not making a functional recovery?
No.
Doesn't make any sense, right? So first thing that I want to tell all the viewers is that the priority or importance that are given to the surgery equally has to be given to the rehabilitation phase as well. Okay. But having said that, taking to the rehabilitation phase 1 month after the surgery, 2 months after the surgery doesn't make any sense to me, at least. Okay, as a neuro expert, I don't think taking to a rehab center after 1 month makes sense. Physiotherapy and rehabilitation has to start then and there, immediately after the day of surgery. And it has to be ongoing and guided and expert regulated program, right? So if it hasn't been started early, if it has been totally neglected, if it is not under the guidance of an expert, if it is not done by a proper multidisciplinary team, definitely the results are not going to be great. Okay, so don't just focus on the surgery itself. Surgery is just 50% solution to the problem. The rest 50%, the rest half lies in the rehabilitation program. It has to be done early, it has to be done by an expert, and it has to be ongoing till you get the final end result that you desire to.
Okay. So rehabilitation has to be part of that recovery program. It's
yes.
not an optional
Rehabilitation
kind of
is not an option, it is a must to have.
Okay. Doctor, generally what are the mistakes usually patients or patient attenders do which will impact their delay of recovery, in fact of choosing rehab? So what exactly may be the point?
So usually if you take the disc problems or any spine surgery, the patient usually goes back home walking, majority of the cases, elective cases at least, okay. So patients will be under the impression that we are walking, we are good, the pain maybe has significantly come down. So let me do my own physiotherapy. I will decide what to do, how much to do, okay. In spite of advising them that this has to be done at this particular time, you can do these activities now, you follow these precautions, avoid these few activities, and then start going to physiotherapy at this point of time. These are the exercises that you have to do now. These are the exercises that you have to do lifelong, maybe neck strengthening, back strengthening,
Yes.
okay. So they maybe take this on a lighter note, they may not prioritize this. So usually what happens is, we send the patient in a good shape with reduced pain, they come back after a few months or maybe few years, you never see these patients. As a doctor, what we feel is, as a surgeon especially, the patient doesn't come means he's doing good is what we think.
Yeah, exactly.
Okay, because if he has a problem, he should come back to us.
If he's not coming,
So we feel that he's doing good, so he's not coming back to us. So they come back to us after 3 years, 8 years with a recurrent disc bulge or a repeat of the problem. It's going to be a re-stenosis. So what is the problem here is, they are missing the precautions. They are not doing the physiotherapy. Sometimes patients, when they come to my OP, I ask them, what physiotherapy are you doing? Just show me. They are like, they look here and there just to escape this. So if you do regular physiotherapy, it doesn't take much time to just show it to me.
Yes.
So it has to be done this way only, there is no second option.
Okay.
So your back has undergone some changes. It could be because of my surgery and it could be because of the previous disc problem or the degenerative changes. So you have to follow the precautions, you have to go to a good physiotherapist and get the exercises done. And remember, these exercises it is better to do lifelong. I tell my patients, you go to a tour, you go to Malaysia, you go to Singapore, will you forget brushing your teeth on that day? No, right? So why do you miss exercise on that day? It hardly takes 10 minutes of your daily time. So follow the precautions, do the exercises well. A correct person should guide you, mainly the physiotherapist should guide you what exercises have to be done. Some people are doing exercises by just watching the YouTube also.
Yes.
So what I say to my patients is, YouTube doesn't give you a feedback whether you are doing the exercises in the right manner or not. So you have to do this exercise in the right manner. Go to a good physiotherapist, let him assess you, let him give you the guidance on which exercises you have to do, okay, so that you have a feedback. He is talking to you, YouTube doesn't give back you answers. So he is telling you, and then please do follow that. If you have any problem, get back to him. So this is the way we do. And like in spine injury, mostly because of some various constraints, they don't go to the rehab center also. We discuss this earlier. I feel very dejected when I see the patient coming back in the same wheelchair in the OP. So these things have to be prioritized. Surgery is not the end solution. Especially in a disc problem, it is a lifestyle change. And then doing exercises should be done in the proper way with proper guidance. Everything makes, everything is very important in the recovery process.
Does this happen anytime in your practice, doctor, that patient, you advise them to go to rehab? After 1 month or 2 months, they come back with the same problem without any progress. They may in fact tell you that, sir, you advised for rehab, we went for rehab, everything, we were there in rehab for past 2 months,
yes.
but nothing is there. But what exactly may be the reason in this point?
So most of the times, like, patients feel confident after the pain has come down. If the surgery is too successful, that the pain has come down significantly, the patient starts walking immediately. Especially with endoscopy, we make the patient walk the very evening itself after you do the surgery in the morning.
Same day, okay.
So patients feel that I'm already walking, what more should I do? But the point they are missing is that changes in the back are permanent. You can't reverse your aging process, right? So you have to maintain the system there and then train to strengthen the muscles. Okay. So these patients who miss the things come back with some minor problems. Patients who follow the precautions most of the times don't come back with any major issues. Okay. So it is very important to follow the precautions. Some patients ask us, as a doctor, why don't you only teach the exercises? So, the role of physiotherapist is very much underestimated in this society. And this is, I feel very bad regarding this, You can't ask the physiotherapist to operate, right?
Yes.
He can't do the surgery. So each person has his own expertise. The physiotherapist has his expertise in assessing the patient, and he will be the correct person to tell him what exercises have to be done. There are so many exercises for the back. So which are the 5-6 set of exercises which this particular patient needs? Is the expertise of physiotherapist.
He can assess.
And even I also don't like to refer physiotherapist about, do ultrasound therapy, do laser, do this, do that. most of the physiotherapists are very well trained, especially in a good center. They have all the equipment, they are very well trained to assess for themselves and then choose the right methodology of getting their pain down or training them for good exercises. So like I said, people will ask me only to guide regarding physiotherapy also. So I am a surgeon. You go and ask a physician, they also won't be able to guide you, right? So like people are aware of various doctors. There is a pediatrician to take care of the kids. There is a general practitioner who takes care of grossly all the medical issues. There is a surgeon whose main role is to do the surgeries. Yes. And there is an oncologist who takes care of the cancer and related issues, the medical part of the treatment. There is a radiologist whose main job is to report or get the scans done, right? So there is another branch called PM&R, Physical Medicine and Rehabilitation. So these people are trained, they do a proper degree where they are trained to take care of the patients in the post-operative period or take care of the pain of the patient, manage the pain and then get them back to track to take care of their activities of daily living. Okay. So it's a specialized branch. These people spend some years to get trained in these aspects, post-surgical recovery. It can be not just neurosurgery, it can be cardiac surgery, post-lung issues like pneumonia. Post-COVID, there was a lot of demand for this branch. Yes. Okay. So people were having compromised lungs. So they did a lot of things to improve the lung capacity. So everything has to be guided and tailored. So these people are the experts who decide like how much physiotherapy has to be done to a particular patient. Is this the right time to do this modality for this patient? Okay. So is this patient a candidate for this modality or is some other modality beneficial? And how many days he has to come to the rehabilitation program? How quickly can you send him back to work? So these decisions are also being taken by discussion along with our PM&R specialists. It's not just me or a surgeon who decides this. The discussion has to be taken in a combined manner after discussing with the PM&R also. So just to highlight that PM&R, there is a branch which exists and these people are experts. And believe me, these people are experts in getting you back on track. Yes. After post-surgery or after various illnesses.
Yes. Even when I interact day to day with the doctors, most of the doctors even doesn't know much about this PM&R branch because usually they will term them as a physiotherapist only, the experience in physiotherapist or something. So that was great insight, doctor, learning about PM&R and their role in that recovery part is something which no one knows in day to day, even the doctors.
Even some PM&R specialists, they also start medicines to take care of the spasticity part. Yes. Because they have a medicine background. They also give some medicines to take care of the spasticity. Okay. They also are aware of some medicines which help in neural recovery, the neuroprotective medicines or some other medicines which we use for recovery. So they don't send back to us also. So they have the expertise in taking care of the medical part also. Okay. So they take care of whole and soul of the rehabilitation program, not just physiotherapy.
Okay, that holistic care.
Holistic care, yes.
Doctor, most of the times when patients done with the surgery, to say you on lighter note, they will care hospital, this and everything. When you advise them to go to rehab, will they ask you that, sir, what will be the price? Sir, is it for lower side? Even if their affordability is there, but most of the people are not willing to spend on physio part or anything. They think that surgery is done, most of the thing is done. Is these kind of things are extra cost which they are paying from their pocket? So what do you take on this?
So yeah, we commonly see this type of situation in our main hospital. So fortunately, because we do the surgeries most of the times and then most of the stay in the hospital is in the intensive care unit, they accept the bills. Okay. At least the affordable lot accept the bills, right? Because they know that this is the main part of the treatment. If you don't do the surgery now, it is going to have a significant impact on the future. He's not going to make it. If it is a life and death thing, he's not going to make it. Or if you're not going to operate now, maybe he will permanently lose power in the limbs, right? So to some extent they accept, okay? But once we tell that, the part of this part is over now. Okay. So we have to go to step 2 now, the rehabilitation phase. So they will have some laxity, The usual question that they ask us is, we have spent so many bucks here. So should we spend again there? So what I want to tell everybody is that, these rehabilitation centers are also as good as the main hospital in terms of infrastructure. Like we were talking about robotics. So if you install a machine with robotics in your center, it comes at a cost, right?
Yes.
So it has to be charged on the patient. So, and other equipment, every equipment, having a staff let it be the main hospital or in the rehab center. You need to have a lot of staff. You need to have multiple PM&R people. You need to have people involved in the psychiatrical counseling. You need to have other doctors who are involved in vocational rehabilitation, pulmonary rehabilitation, cardiac rehabilitation. So you need to have a lot of staff. Most of the times in a very decent rehab center, the staff is as good as that in a big hospital, big corporate hospital. So to maintain the staff and to maintain the equipment mainly, it comes at a charge. So I try to explain from my side that let us not waste all the efforts that are being put in the first hospital here. Just please be patient for maybe another month or so. Let us see how the recovery is going to happen. Having said that, if they still ask about finances, I say I am not the right person. You can just go, because most of the patients do a bit of shopping. Yes. They go from center to center. But I say, see, good team and a good center comes at an extra cost. On a funny note, I would maybe end up saying that you can try discounts from your side. You just try asking discounts. Yes. But I want to emphasize that these centers spend a lot on installing the equipment, and yes, the staff is also too many. The floors have to be clean. Patients or their attenders want the floors to be clean. They want the wards to be neat. They want all the staff. But this can't happen at a lesser cost. Probably I think the future India should see is even the rehab centers should have good tie-ups with insurances or maybe EMI facilities, because most of the time they will already be exhausted after making a big bill in the primary hospital. So maybe EMI facilities or maybe some schemes can come, probably from the government side, so that which can aid patients in continuing the care at a rehab center, especially in the main good rehab centers.
So I'm happy to share that, doctor, as you are telling that insurance company has to be tied with the rehab. Across India, we are the rehab which had tie-up with most of the insurance companies.
That's
even
good. Okay.
We had that EMI facilities where the interest will be taken care by companies. So we try to be friendly on the pocket side also.
Okay.
Providing recovery and being pocket friendly at the same time, we try to give that holistic approach to the patients, because you are treating them, you are making them out of danger, and to provide the quality of life back to them, we are trying our role and we are trying our best to give them the options available with us and everything. So end of the day, we want to work with you as a team.
Yes.
So we like to be that continuing part of your treatment rather than an optional kind of thing.
Yes.
Doctor, after discussing with you, after knowing many things from you regarding recovery part, surgery part, everything, what I feel is families think that after surgery, it is done. Getting discharged from the hospital is the last step. But in fact, what I learned from you is discharge from the hospital is the initial or crucial phase where it begins for the recovery part. So I'm proud to say, rather than I'm very happy to share with you that HCAH Civitas has complete 365 degrees holistic care, which our treatment is led by PM&R, multidisciplinary team is there, advanced robotic equipments are there with us, even that integrated modern Ayurvedic therapy medicine is also there with us. So with all this, we are happy to share that the complete fast recovery is possible with HCAH Civitas. So as I want to say that, because such successful surgery is not the main thing. Complete recovery is what we are looking for, and even what you are looking for your patients.
Yes.
So thanks for allowing us to be part of your recovery part. Thanks for trusting us as your partner in recovering the patients. So we are looking forward to work with you to make your patients get that successful complete recovery after your successful surgeries. Thanks, doctor. Thanks for coming, and thanks for giving us this time. Thank you so much.